we are basically going to talk about some of the issues that occur between the physician and the patient. And in respiratory care, in aerosol science, we find that about 69% of physicians don't know how the devices they order work. It takes about 8 years from the time a new device is approved for physicians to start getting that information in. And the pharmacists, at least in the US, don't do a very good job of training patients. And the products and the devices typically have inserts that are written by lawyers for lawyers. So high school graduate in the US, it's borderline literacy for reading things like that. And we end up with about 60 to 70% of patients who don't know how to use their devices, why to use their devices, when to use their devices, and how to maintain the devices. So I want to go through some of these issues with you. And first, my disclosure, I'm Chief Scientific Officer for Aerogent Pharma. I have nothing to sell. We're developing inhaled surfactant for neonates as a drug device product, and I'm a fellow of aerosol science device development at Dance Biopharma, who's working on inhaled insulin. There's patient-related factors that need to be considered in matching devices to patients' needs. Knowledge deficit, like low literacy, poor comprehension of written instruction, poor attention span. When people are sick, they're not at their best. We used to try to teach people in the emergency room how to use their device when they went home. And it's like, was I in the emergency room? So when you're really sick and desperate and need the training the most, it's the hardest time to be able to train. And we're a very hierarchical society. No one wants to tell the doctors that they don't understand what the doctor told them, or that they haven't been doing exactly what the doctor told them to do. So the training issues, many patients don't receive any inhaler education. They have inadequate information and training materials, inadequate follow-up, limited financial incentives for education. I mean, if it's going to take you 10 minutes, 30 minutes, or 45 minutes for you or your staff to do training on devices, you shouldn't have to do that for free. And the pharmaceutical companies don't pay for it, and the third parties don't really reimburse for it. It's getting a little bit better, but it's still an issue. So the other issues are age, cognitive issues, physical ability, socioeconomic situation, and preference. If you can't afford it, if you got a choice between food or your medication with your fancy inhaler, it's a clear choice. Most people will feed their families first. So there are device-related factors. I'm going to mostly talk about nebulizers because you've got all these companies out here talking to you about their DPIs and MDIs. And the aerosol field has changed a lot in the last 20 or 30 years. Jet nebulizers have been around since the 30s. They have a compressed gas source. They are cheap, relatively cheap. And in the US, we have DMEs who provide, on a prescription from a physician, a nebulizer and a compressor. And unlike Europe, where they can't sell you a nebulizer compressor unless the manufacturer has said how it performs with different drugs, in the US, it's all open. The cheapest compressor they can find, the cheapest nebulizer they can find, and then they can get the full reimbursement from Medicaid or Medicare for that device. So that can be an issue in terms of what quality of device the patient has available to them. The same nebulizer that works in the emergency room when it's hooked up to oxygen or air at 50 psi and makes these really small particles, when you put it into a cheap compressor that's only doing 5 or 6 psi, you now have boulders coming out and it all goes to the back of the throat. So it's not going to be as effective as a device. So one option back in the 80s was the ultrasonic nebulizer that uses a piezo ceramic element. You can see you have a piezo ceramic element, it vibrates, it puts vibration through the liquid, and it creates a standing wave in the medication cup, and those particles are what then goes on to the patient. It's pretty good technology. It was really an innovation from the jet nebulizer because you didn't need the compressor and it was silent, but it doesn't work with suspensions because the particles might be smaller than the drug particles, and that can definitely be problematic because you're delivering a lot of saline particles or whatever the liquid is, but the suspensions of budesonide stay in the bottom of the cup, which is why they recommend not using ultrasonics with suspensions. It also heats, has a lot of heat generation. It's about 3 megahertz. Now the vibrating mesh nebulizer basically has a disc with, say, 1,000 or 4,000 holes. They're funnel-shaped apertures, so the top of the aperture is with the liquid reservoir, and it vibrates at 128,000 cycles per second. It takes about 4 cycles to go from off to full on. So it's just a millisecond, which is really nice for some of the stuff I'm doing. But what it also does is it produces particles based on the holes that are being moved by a piezo ceramic element. So that's gained great popularity over the last couple years, but 10 years ago it was very, very expensive technology. Now it is much more reasonable technology, and there are a number of companies that provide this type of technology. It doesn't generate a lot of heat. It works with suspensions as long as the suspension particles can fit through a 4-micron particle mesh, and generally budesonide is about 2 microns, so it's not a problem. Performance can differ with specific drugs with any nebulizer. So if you have active or a passive mesh, an active mesh is one where the mesh is vibrated by a piezo that surrounds the mesh component. A passive is where you have an ultrasonic horn that's kind of pushing drug through and causing it to vibrate. Vibrating mesh doesn't foul as often. It's a little bit more dependable in my mind. But the big issue is the performance. So if you have a jet nebulizer and you have a very viscous drug, it's pretty similar. If you have a mesh nebulizer and it's viscous, higher viscosity can reduce the output rate and eventually slow it down. Most of the drugs that we prescribe today for aerosol aren't high enough viscosity to make a difference. So the performance can really differ with specific drugs, and cleaning and maintenance is really an issue. I've had patients bring in their nebulizer in clinic after 3 months and it's just black because they never thought to take it apart and clean it, even though they were instructed to. Number of parts and ease of assembly are really important. So, device-related factors. The inhalers can cost greater than $250 a month, depending on what drug you have. Some of them are $400 a month. Even metered dose inhalers have gone from, I remember it used to be $40 for 200 puffs of albuterol. Now it's somewhere in the $200 range. And that gets pretty expensive as opposed to a liquid unit dose that can fit in a nebulizer for 25 cents. Nebulizers can cost $200 per year. If you have durable systems, there's better reimbursement for them. Nebulizer drugs have a pretty large range. We'll look at that. Typically, you can get your drugs for short-acting bronchodilators like ipratropium and albuterol for less than $1 a day. Corticosteroids get a little bit more expensive, and then you get to your antibiotics and prostacyclines, and those are in the $300 range. So it isn't just always cheaper to have a nebulizer, but sometimes it's the only way you can get the drug. There's the Toby Podhaler that has a antibiotic in it now for CF patients, but it's about the only real commercially available inhaler for dry powders. So, here's one of the big problems. There are a lot of different drugs on the market, and almost every company that puts a drug in an inhaler matches the drug with their inhaler. And those inhalers can be kind of problematic because if I have an inhaler for this drug. Let's say it's an MDI. And with my MDI, I'm supposed to go slow and deep, like you're sipping hot soup. Where with my DPI, I have to actively disperse the powder from the capsule, so I have to breathe fast. Okay? Patients often confuse which they're supposed to do with which inhaler. So they have their DPI and they nice and soft and they don't get much drug out of the capsule, or they breathe really fast with the MDI and they get a lot more oropharyngeal deposition. So you'll see a term called device dementia. You can see here there's a number of different devices. This is just a small group of those devices. And you have different treatment algorithms based on the gold grade system. You have a lot of patients who are on LAMA and LABA. You've got your first groups, however, are using periodic PRN bronchodilators, and then we start adding more sophisticated combinations of short and long bronchodilators and inhaled steroids. You're familiar with these. The issue is, where do you want to start your patient, and what options do you have for devices and the drugs that are available? So, tons of different devices. Confusion occurs if the patient has to get trained to do more than one of them, no less 2, 3, or 4. And by the time you've gone up the scale and you've got all these different drugs, if every one is a different inhaler or a different type of inhaler, then you've increased the chances exponentially that your patients aren't going to be able to differentiate and keep them straight. So, aerosol delivery device selection for ambulatory asthma and COPD patients, I'm a respiratory therapist by training, and I started my practice in the hospital, so I thought all aerosols happened in hospitals. Well, about 2% of aerosols happen in the hospital. Everything is out with patients in the real world, and they have needs, whether it's a MDI, a DPI, or a nebulizer. Each patient is different in terms of what they really need, what their lifestyle is, what their capabilities are to be able to operate or maintain the device, and what their financial situation is, and more importantly, what their preference is. So I used to work at a VA hospital, Hines in Chicago, and we had patients come in. I was all hot to get them on MDIs and valve holding chambers. And this one guy came in and said, they told me I have to drop off my nebulizer to get this MDI. And I said, well, we think it'd be more portable. You might like it. And he said, well, but I like my nebulizer. It works for me. And I said, well, can you use an MDI? And he said, yeah, I know how to use an MDI. I have one of those too. So I asked him to show me how to do it. And he shook it, and he put it in his mouth, and he was perfect. And I said, so what's the problem? He said, well, when I'm short of breath, I can't do that. I don't know if I'm breathing in or out. So then you need something like a valve holding chamber to make a difference, right? So the preference of the patient is really important. Now, the sideline is, I gave him a spacer with the MDI. I said, take your nebulizer, take this with you, come back and drop off the one you're not using. And we got the nebulizer back. But that's not always the case. Some patients get much more benefit from the nebulizer. They get a much bigger dose, 2.5 milligrams rather than a couple hundred micrograms. And it's really the patient's preference and how they respond to the different systems. So you want to evaluate the patient's physical ability. You want to be able to see, do they have hand-breath coordination? You know, are they blowing out when they're supposed to be breathing in? Can they produce inspiratory flows greater than 30 liters per minute? Because your dry powders often require 60 to 90 liters per minute to be able to get most of the drug from the capsule or from the dosage form emitted as aerosol. Yeah? Some of them are getting much better and work at 30 liters per minute, but you need to know which one of those are for the patients who can't generate high flows. Does that make sense? So, MDIs, DPIs, nebulizer for patients who can generate higher flows. If it's lower flows, MDI, nebulizer, or the soft mist inhalers, but you want to avoid the dry powder inhalers. If they have poor hand-breath coordination, MDI is not a good option for them. Inspiratory flows greater than 30 liters per minute. MDI with valve holding chamber, because it's breath actuated. But you know, I was visiting my mother-in-law on her 90th birthday 2 weeks ago, and she had a cough, and she had some albuterol, and I said, show me how you take it. And she shook it, and she opened it, and she's sitting there with both hands trying to get this thing actuated, and she's just lost a lot of hand strength. She doesn't even have arthritis. And so it was really hard for her to be able to actuate the device. So I got her a spacer at least so that she could, a valve holding chamber, so that she could at least get it in and then take the breath to get the medication. But this is someone who'd probably benefit better with a little nebulizer and a couple of drops of albuterol in it when she needs it because it helps her cough. But that's another story. So for poor hand-breath coordination, if they're less than 30 liters per minute, then MDI with valve holding chamber or nebulizer, avoid MDI and DPI again. Now, you want to be able to evaluate patient-related and device-related factors. So the patient-related is preference and willingness to use. If they get an MDI and it tastes terrible to them, a lot of people, when they change formulations of MDI, say, this tastes funny, I don't want to use it. Age and cognitive ability. When you get up to my age, cognitive ability is pretty much shot, and it's going south fast. Need for mobility. So if there are people who are 70, 80, 90 years old who are out and about all the time. They don't want to be tied to a compressor nebulizer at home. And honestly, they'd probably not like to have 5 different devices they're packing with them. Maintenance and cleaning is really important, ease of use, and cost reimbursement. And if you're ordering stuff for your patient and you don't have an idea whether they can afford it or not, you're not doing them a big favor. And I've said that before, and people said, that's not my job. I evaluate the patient, I prescribe what they need. Well, they need a prescription that they can afford and that they can use. And it's part of the job that, frankly, we don't teach in medical school, we don't teach in our residencies, and we don't particularly teach well in our fellowships. And it's about $2 billion a year waste for our industry. So, as I mentioned before, there's a lot of drugs that are available in MDI, DPI, and there's also for nebulizers. This is just a partial list, but I just wanted to kind of make it clear that each one of these MDIs or DPIs tend to be in different formats. In Europe, you've got the Respimat from Boehringer, and they've got an increasing number of drugs that are in that smart mist inhaler. They're on the right track. In the US, we have a couple available with them, but then you have, look out into the vendors. You're going to see a lot of different DPIs and MDI configurations. And then you have nebulizers. And nebulizers actually the same nebulizer can cover a broader range of formulations for patients. And whether someone has bad hand-breath coordination, whether they breathe in when they think they're breathing out, these nebulizers are all continuous. So if they're just breathing it tidally, it's basically the easiest format for many patients to use. However, many of these nebulizers have 5, 6, 10 parts, and they have to clean them regularly or else they're going to start nebulizing bacteria and pathogens, which you don't want to get into the lungs. Yeah? So, this is just an example for a device. This is one device, and it's a vibrating mesh nebulizer, and the company has published data to say this is the particle size, mean mass aerodynamic diameter in microns, and these are salbutamol, ipratropium, and budesonide. And here's the particle size ranges. Here's the respirable fraction. You can see it runs from 64 to 52%. Here's the basic treatment times and the residual volume that's wasted in the nebulizer. Now, jet nebulizers generally hold back 1 cc. Sometimes it's 0.8, sometimes it's 1.2. But you only nebulize a portion, probably about 60% of what you put into that nebulizer. The mesh nebulizers can be as low as 1/10 of a milliliter. So if you put in a 2 milliliter dose of budesonide, you're actually nebulizing 1.9 milliliters, which means you're wasting less drug, which is good. And the other component is how easy it is to clean. And if you have something that's a two-piece device that you can rinse and just air dry, you're going to be in better shape than having something that has 6 or 7 pieces, and if you get a component backwards, like a flow valve, it's not going to work very well at all. So these are elements of consideration there. It's important to understand what the patient's preference is. If you're managing a patient who's ambulatory, you see them periodically, it's really good to say, how are your inhaled medications? Do you know how to use them? Do you know when to use them? And you don't ask them that because they're going to say, yes, sir, yes, ma'am, I know how. I've been doing what you told me to. It's always nice to have them bring in some their devices and show you or your staff how they use them and get a little correction. Demonstration, return demonstration is really, really important. And if you use written instructions without hands-on demonstration, it's just like not doing any instruction at all. The Harvard Literacy Project said in Boston, high school graduates, only 70% of high school graduates could read their label on the pill to know how many pills and how often they're supposed to take them. So don't take literacy for granted. Yeah? And then you have English as a second language. So the check for usage errors, someone needs to say, here's how you use it. And I'm old enough to remember Jane Fonda and her workout tapes. And it revolutionized exercise at home because people didn't have to remember the exercises. They could see Jane do it and do it along with her. That's exactly what we need for patients with their devices. Someone, you or someone in your office or in your clinic, needs to train people how to use it properly, and then have a placebo so that they can, you want to demonstrate, let them return the demonstration, and then correct their technique. And every couple of months when they come in for a visit, have them bring their devices, and if they're doing it right, great, give them the attaboys. But if they're not, you can correct it, and maybe they will respond better. So my friend Rajiv Dahand, he was at the Heinz VA with me, and he saw a patient in clinic one day, and he said, what's the problem? And he said, well, I've been taking this inhaler, and it just doesn't seem to be doing any good. And they've been stepping him up from a low-dose inhaled steroid to higher, to higher, to higher. And this is the first time he saw the patient. He said, so it looks like this drug isn't doing you any good. Can you show me how you use your inhaler? And he said, sure, I'd be happy to. He takes his MDI, takes the top off, he puts it in his lips, he exhales first, he puts it in his lips, he breathes in nice and slow and deep. No, he didn't do that. What he did was he took the device, took the mouthpiece off, and sprayed it on the back of his neck. And Rajiv, being far more polite than I was, what the are you doing? And he said, well, when the doctor ordered this for me, he said, whenever you're short of breath, spray this to the back of your throat. And this patient said, back of my throat's the back of my neck. So he had a terrible rash. And so he backed off the dose, showed him how to use it, gave him a valve holding chamber, and the patient responded at a low dose 3 years after he'd been initially prescribed. So education is really important. Here's a short case study as we start to finish up here. So John's 65-year-old man with COPD has arthritis. He works part-time as a night shift security guard at a trucking company. He also travels a lot to see family and friends when he's not working. He's got shortness of breath and dyspnea, no variation seasonally at night or in relation to possible allergen exposure. His symptoms increase with cold air and when he gets around irritants like perfumes, secondhand smoke, and diesel fumes. He's got expiratory wheezing. His current meds are DPI LAMA, where he's supposed to take one inhalation QD, MDI short-acting, which he uses his albuterol about 20 breaths a day. That's a clue. And he has a beta-2 agonist, that short-acting muscarinic combination, albuterol iptromin, which he uses 2 to 3 times a week. So, he says he has no medication side effects when he uses 20 puffs a day, and the question is, what's going on with him and what can we do about it? So, Does he have cognitive issues that may prevent him from following instructions? No, he holds a job. He's pretty lucid. Can the patient coordinate actuation of the MDI with early inspiration? Yeah, we're not so sure. Can he actuate the MDI? Seems like he can do that. Can the patient generate an adequate inspiratory flow to use the DPI? We don't know. Can the patient handle the device following all the steps for correct use? You have to find that out to find out something's not working here. Now, obviously, one of the things that's not working here is he doesn't understand his inhaled steroid and how that's supposed to work. He instead of doing PRN with his puffer for albuterol, he should be really using the ipratropium albuterol combination, not 3 times a week, but 3 times a day. So making sure he understands his prescription is a big deal, but then also finding whether he can afford his medications and does he have a preference for the devices. So the patient takes a quick deep breath and then actuates his MDI into his mouth. Let's see. That's puff. That's what we call head breath coordination. He doesn't have it. He could do 40 puffs a day and he's not going to get much. DPI, patient prepares the device, holds it in the correct position, exhales away, places it in his mouth, and inhales slowly, sipping the soup. So he's not getting that drug. And what can we do about that? Well, consider aerosol delivery characteristics, assess the patient and caregiver's abilities, needs, and preferences and costs, review device for ease of use, evaluate and continually monitor use of the device and the patient's compliance with this prescription. If the patient doesn't know what he's supposed to use when, and he gets it out of order, that's contrivance or just, oops, I forgot. As I get older, I do that a lot. I still contrive, but if they forget and they're using the stuff that's supposed to be PRN all the time and they don't use the steroid because it's too expensive for them or they don't understand that it's long-lasting and it really cuts a lot of their side effects, you're just wasting a lot of expensive medication. So our involvement from the clinical side, whether it's the prescribing physician, the support of clinic or office staff, to the patient advocates themselves, we make a huge difference in how our patient can be controlled with their medications. It's 90% education, 10% medication. We'll be talking here for the next 3 or 4 days about all the things happening to make it better medication for COPD. But we got what we need for asthma and COPD to cover 95% of the patients who need it today, but we're not getting it into them to get the effect.